anemia, high output states, where there is a strain of the ventricle, the sepsis, mitral regurgitation, all these can produce an elevation of natriuretic peptides. It doesn't mean that there is heart failure there. But the second part is more interesting. You can have a heart failure and still have a normal NT-proBNP in obesity. Flash pulmonary edema, acute pulmonary edema, suddenly it may not be there. Pericarditis producing like cardiac failure can be there. Genetic polymorphisms and end-stage cardiomyopathy, where there is a burnt-out cardiomyopathy, the NT-proBNP levels can be normal. Mind you, it can still be normal and have cardiac failure. Today, what is more interesting is the focus or the point of care ultrasound is very useful in clinical practice. Now, the picture that I show you here, you see these longitudinal lines that are there. These are the lung ultrasounds. What you see as these longitudinal lines are the B lines. If you find more than 3 B lines, it is suggestive of a pulmonary edema, the congestion. So, in a point of care ultrasound, in an emergency, if you have a look at the LV, and even if you are not able to look at that, if you are able to do an ultrasound of the lung and show multiple lines like this, now look at this. This has got 1, 2, 3, 4, 5, 6, close to 10 lines. Clearly classical pulmonary edema in the right sided picture that you're seeing here. So this is going to be very, very useful, and this is going to be the future in which the way in which we're going to diagnose an acute heart failure. So basically, we spoke about 2 kinds of heart failure. Actually, there are 3 kinds of heart failure. Heart failure with reduced ejection fraction, wherein the ejection fraction is less than 40%, and the heart failure with preserved ejection fraction, where the ejection fraction is more than 50%. Between 40 and 50 is given multiple names. Borderline ejection fraction, mid-range ejection fraction. What I like to call it is probably mildly reduced ejection fraction. But in these 2 conditions, the elevated natriuretic peptides are very important in diagnosis of heart failure. Once you've made this diagnosis of heart failure, what is more significant? Is it going to be the reduced ejection fraction, borderline ejection fraction, or the preserved ejection fraction? Mobile is on. Right. So which is going to be more important, the reduced ejection fraction or the preserved ejection fraction? Now, if you look at a person between 60 and 65, this is normal life expectancy. Look at the blue bar, which is reduced ejection fraction life expectancy. The orange is the borderline and the gray is the preserved ejection fraction. If you look at it, all 3 have the same ultimate median survival. Meaning, heart failure with reduced ejection fraction and preserved ejection fraction are equally bad. Remember that both are equally bad. So if you make a diagnosis of heart failure with preserved ejection fraction, it doesn't mean the patient is going to be fine. They're going to die as much as the heart failure with reduced ejection fraction. So once you made a diagnosis, I did not go too much into the cardiac MRI and the ventriculography, doing an angiogram to rule out coronary artery disease. I've kept it very practical and clinical because in 15 minutes this is what I can tell you. So what is the choice of therapy? There are multiple choice of therapies. You have the ACE inhibitors and ARB with several trials backed up, the beta blocker trials, the MRAs, the spironolactone and the eplerenone showing 2 significant trials, and the newer trials with the neprilysin inhibitor or the ARNIs, the SGLT2 inhibitor trials, 2 major trials have come up, the vericiguat with the Victoria trial and the ivabradine with CHIP trials. All these drugs are there. So what are you going to choose when is what I'm going to tell you. I'm not going to this. All these trials have been positive trials and all the drugs have been proven to be effective in reducing mortality in heart failure. So what is going to be the drug that we're going to do? The first trials came in with ACE inhibitor and ARB, which showed a 20% reduction in sudden cardiac death. Now, on top of which, when the beta blockers were introduced, there was an additional 42% reduction in sudden cardiac death. So, in addition to the placebo and the ACE inhibitor. Now, in addition to these 2, when the MRA came in or the spironolactone trials came in, there was an additional 19% benefit. So, there is additional benefit. Finally, when the ARNI was replaced by the ACE inhibitor, there was additional 22% reduction. So clearly indicating these 4 drugs reduce sudden cardiac death. They are going to be the backbone or the cornerstone of therapy. Now with this as the background, the heart failure treatment is going to be like this. All the patients should have a RAS inhibition. ARNI is preferred. Clearly ARNI is superior to the ACE inhibitor, so the ARNI is preferred. I'm not going to do too much of numbers. So just remember the ARNI is the preferred. The second one is going to be evidence-based beta blocker. There is evidence for only 3 beta blockers, the carvedilol, metoprolol and bisoprolol. So only these 3. And what dose will come to next, with or without a diuretic as needed. So when these 3 are given, the first 2 drugs are given, the third one is you look at a patient's EGFR, look at the potassium and the creatinine. Creatinine less than 2.5 in men or less than 2 in women, with the potassium less than 5. Add a spironolactone or an eplerenone. So this is going to be step 1. If you don't get this in, and if you're still a patient is a candidate for SGLT2 inhibitor, start one, about it we will come to subsequently. And if your diuretics are going to be there, if going to be required, you add a diuretic. So when is a diuretic beneficial? in chronic heart failure. One thing you must understand, diuretics do not give mortality benefits. Diuretics only provide relief from congestion. So you can put a patient on a reasonable salt restriction, fluid restriction of about 1.5 grams and 3 grams of salt, monitor weight daily. If there is going to be a 3/4 of a kg weight gain per day or a 2 kgs per week, you can probably add a diuretic on a need-only basis because they don't improve survival. So diuretics are not mandatory. Now, there's a very important study and data that came up last year which clearly showed that if your patient has got a heart failure readmission, look at no loop diuretics and light diuretics. If the patient does not have any congestion, loop diuretics worsen the prognosis. So if there is no congestion, loop diuretics do not benefit. Again, look at edema. If there is no edema, the patient is going to have a higher mortality. So the loop diuretics are going to be beneficial at discharge only if you have a lung congestion or a peripheral edema. Otherwise, you don't have to discharge a patient on diuretics. What we commonly do, we put them on diuretics. They're not required. Actually, if you put the diuretics in the wrong patient, the mortality is higher, which I wanted to convey very clearly. Once you have done this, the next step is going to be to look at the beta blockers in a little more important fashion. Why do we keep talking about beta blockers and increasing the dose of beta blockers? The MOCHA trial on carvedilol had a very beautiful answer. Now look at placebo, 6.25 mg twice a day of carvedilol. Then look at the 12.5 twice a day and 25 mg. The ejection fraction progressively improved. And look at the mortality progressively decreased. So the higher the dose of beta blocker, the ejection fraction improvement was clearly made. So there is a clear case of not starting beta blockers for the sake of starting beta blockers. You don't just start it, you have to give it at an adequate full dose because there is an incremental benefit clearly made out with beta blockers. So what you have to do is, if you're going to give bisoprolol 1.25 mg, start, go up to 10 mg. Carvedilol 3.25, go up to 25 mg twice a day for 85 kilos or less. 50 mg twice a day for if your weight is more than 85 kilos. Mind you, these dosages are not heard of. Now, metoprolol, if you want to give, you have to go up to a maximum dose of 200 to have the maximal benefits. And we have clearly shown an incremental benefit. What about ARNIs? ARNIs, you start at 50 mg twice a day. The BP is low, even half the dose, and then go up to 200 mg twice a day. There is a clear benefit, but at all doses, ARNIs show benefit. It is not that only at 200 mg there is a benefit. The benefit is there at smaller dose. The drug which most commonly promoted recently, because several companies came up with ivabradine, is the ivabradine which is used. So when do you start ivabradine? In a heart failure with reduced ejection fraction, you start them only after you give the maximum tolerated dose of beta blocker, and then still the heart rate is more than 70. You target a heart rate of 50 to 60. Don't get scared. You can target a heart rate of 50 to 60 in heart failure with reduced ejection fraction. Don't panic. If the heart rate is more than 70, you bring it down up to 50 to 60, there is benefit. So try to target a dose of 50 to 60. Having said all this, how much do patients get? Now this is a trial that was presented by Mutaya Vagudanathan. He looked at the CHARM data and said the number of patients who are getting the 100% target dose of ACE inhibitor or ARB are only 10% if they are not diabetic, 12% in diabetic. Beta blockers, 18 to 23%, not bad. But look at ARNI. Only 1% are getting the full dose. What about MRA? That seems to be the best drug because MRA dosing schedule is very easy. You have to give about 25 to 50 mg of spironolactone, which most of us give. So the best drug seems to be the ARNI, but most of the patients are either not receiving the medication, close to 40% of the ACE inhibitor. Beta blocker usage is much better. ARNI usage is very poor. MRA usage is poor. Now mind you, this study came up in 2020. So even now, the usage in the US is much, much less. So, but why do you want to use these drugs? Because if you start using these drugs, the benefit is clear. The mortality over 2 years, if you don't use any of these drugs, is 35%. If you use ARNI alone, it comes down to 25%. If you add a beta blocker, it comes down to 16%. Spironolactone, 11.5%. If you add an SGLT2 inhibitor, further comes down. You can bring down the mortality to 9.5%. So it is very, very important that we use all the drugs to reduce the mortality in most of these patients. So how do you start these patients and how do you titrate these patients? Now this is a slide stolen from Greg Fonero. He has said on day 1 of chronic heart failure, you can actually start the ARNI, beta blocker, MRA and the SGLT2 inhibitors. The next dose titration for a beta blocker can be done within 7 days. But to increase the dose of ARNI, you're going to take 2 weeks, not before 2 weeks. And you can also titrate the dose of MRA as required. SGLT2 inhibitors are wonder drugs because you start them on 10 milligrams of dapagliflozin, or 10 milligram of empagliflozin. That is one single dose, and you don't have to do any further titration. So the single point drug, or the easiest drug to give, is going to be the SGLT2 inhibitors, and dose-related benefits are maximum with actually the beta blockers. Beta blockers start the dose of, the priority is going to be to increase the dose of beta blockers before you increase the dose. Clinically, what do? We try to reduce the beta blockers, push up the ivabradine, and we don't give adequate importance to the beta blockers. Mind you, the beta blockers have the best benefits. So the first priority is going to be to increase the dose of beta blockers. Now, when you start using this polypharmacy, what happens? The commonest thing that happens is hypotension. So how do you tackle the hypotension? The hypotension, the common thing that we think is any fall in blood pressure, 100 or 90 is the problem. No, it is a symptomatic hypotension that is important. So don't panic on the hypotension. If you have hypotension, remove all these other drugs, nicorandil, nitrates, the calcium channel blockers, the diuretics. Most of the times, the hypotension is because of overdosage of diuretics, which you have already seen. Coenzyme Q10, L-carnitine, all these drugs have no benefit. Don't waste your money on these drugs. L-carnitine is expensive. Coenzyme Q10 is expensive. Don't waste your money on all these useless drugs. Use them. Use beneficial drugs. And when you start timing these drugs, all the beta blockers, MRAs, ARNI, and SGLT2 inhibitors start showing clinically relevant benefits within 30 days. On day 28, when you use the DAPA heart failure trial, when you use 10 milligram, there's a 49% reduction in events within 4 weeks. 39% reduction in a person who is taking the soloist trial. This is the SGLT1 and 2 inhibitor trial, about which I'll come to shortly. Emperor Reduce had the fantastic results. What it showed, the statistical significance was shown within 12 days, clearly showing SGLT2 inhibitors should be started very, very early in heart failure. So the benefit, statistical significance start probably is the earliest when you start using SGLT2 inhibitors. Now this is for the sake of completion, because we have spoken about ivabradine. You can use a CRT whenever you have a refractory heart failure with a QRS widening more than 130. And in resistant heart failure, there is a role for digoxin. Today, because digoxin is found to be pretty useful, especially in heart failure with atrial fibrillation, you can also start using isolazine or the isosorbate dinitrate with the hydrolazine combination in refractory heart failure. These drugs are pretty useful. Now, in the overall summation, we have found that 4 drugs are useful: the neprilysin inhibitor, the ARNI, beta blockers for the beta blockers, the aldosterone inhibition, the SGLT2 inhibitors, or the any kind of RAS inhibition. Now, in addition to this, the isolazine has been found to be having some benefit. Ivabradine, whenever the heart rate is low, the myosin activator, the very what comes in recently, and the guanylate cyclase inhibitors. These drugs are coming in shortly. IV iron is something that we have often neglected. I think we should all remember that whenever there is a symptomatic patient on good drugs, if your hemoglobin is even less than 15, you look at serum ferritin levels and TSAT, the transferrin saturation. If your hemoglobin is more than 15, don't bother. But if it's even less than 15, if your ferritin level is either less than 100 or the ferritin level of 100 to 299 and a TSAT less than 20, you can still consider IV iron treatment. The iron ferricarboxymaltose is available. You can give 1 gram, and if there is a problem, you can recheck after 3 to 6 months and keep supplementing iron. Clinically, definite symptomatic relief. I have had several patients like this, and whenever I supplement iron, even when the hemoglobin is near normal, continuous symptoms, you look at iron deficiency, start treating them, they're going to benefit. Now, this is a very important slide that was published in 2021. Now, this slide shows that if you're initiating a beta blocker between heart failure hospitalization, no heart failure hospitalization, for an ACE inhibitor or an ARB, for an R, the hazard ratio is going to be 2.62. If you have a dose escalation, it significantly comes down to 1.71. If you de-escalate, it goes up to 2.96, and if you discontinue this drug, it goes up to 3.16, meaning the heart failure hospitalization goes up by 3 times. Now, the same pattern is found with ARNI, the beta blockers, and MRA. The reason why I put up this slide is it is not only important to initiate the drug, dose escalation is very important. If you de-escalate, try to re-escalate again and go up to the optimal dosages. That is very, very important. And once you have these patients on treatment, there is a new category of patients that are coming called heart failure with improved ejection fraction, which we notice off late. You put them on all these drugs, the EF, which was 25% and 30%, improves and comes to normal 60%. Now, what do you do to these patients? Commonly, what is it? You have improved, stop all the drugs. Now, if you stop all these drugs, there is a 40% recurrence of heart failure. So please don't stop these drugs. The 3 drugs that are really beneficial are the RAS inhibition, the aldosterone antagonists, and beta blockers. All 3 have been found to be beneficial. So if you have this new category of heart failure with improved ejection fraction, don't stop this drug. Now, 3 slides on heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction is very, very important category. Now, you must remember, in heart failure with preserved ejection fraction, it is not a single entity. It is a multifactorial disease with several of these dysfunctions happening. The common problem is the echocardiogram. When you do an echocardiogram, you get very important clues. How does the echocardiographer usually report? LV diastolic dysfunction, grade 1, grade 2, grade 3. That is the wrong diagnosis of diastolic dysfunction. If they give it, ask them to grade it properly. You look at an average E by E dash of more than 14. Look at the septal E prime or the lateral E prime. I'm sure the cardiologists will understand this. It's going to be a little high funda. But if you have the septal E prime or the lateral E prime, this is a tissue Doppler imaging, less than 7 or less than 10, the second category, TR velocity more than 2.5, and the LA volume index of more than 34 ml per meter squared. Now, if you have two of these positive, there is intermediate diastolic dysfunction. With more than 3, there is diastolic dysfunction. Otherwise, it is not relevant. If you do a more careful diastolic functioning test, you will be able to come to a very definite conclusion of heart failure with preserved ejection fraction. And treatment of this has become very tricky because there's no proven drug. That's what we said. But no, there are 3 proven therapies. I will show you what the 3 proven therapies are. There is a specific phenotype of the heart failure with preserved ejection fraction, obese diabetic with inflammation, or the metabolic syndrome, and a mild renal injury. They respond well to spironolactone. Now, these group of patients have a statistically significant improvement. One subgroup of patients benefits from spironolactone. This is one. The second group of people who are going to benefit are the patients who are going to take the ARNI. You'll be surprised. Everybody says that the Paragon trial is a negative trial. Now, the US FDA in December 2019 came up and supported the extension of indication of the ARNI in patients with LV ejection fraction less than 57%, which is the median ejection fraction. So if you have a heart failure with preserved ejection fraction and the EF is less than 57, you can still give ARNI because there is a 22% statistically significant benefit in these patients. It's more so in women. So women with LV ejection fraction less than 57%, you can use the ARNI. Now the third newest drug is a new drug that has come in, which is the SGLT1 and 2 combined inhibitor. Now if you combine the 2 major trials called the Soloist and SCORED, I can't go into the details of it. This was one trial which showed a statistically significant improvement in heart failure hospitalization, urgent heart failure visit, and cardiovascular death. This is the new sotagliflozin that is not yet approved, but this trial is the one trial that has clearly shown that there is a first drug that has shown a clinical improvement with heart failure with preserved ejection fraction. So finally, the last 2 slides is this. For heart failure hospitalization or a patient with heart failure with reduced ejection fraction less than 40, there are 4 pillars that are going to be given. The 4 pillars are ARNI, beta blocker, MRA, and SGLT2 inhibitor. Now, if you use all these 4 pillars, you just need to treat 4 patients over 2 years to make 1 patient survive. Mortality benefit is 4 for 24 months, which is the best that we have seen so far in any kind of treatment. 4 patients treated over 24 months, you're going to save. So remember these 4 pillars: ARNI, beta blocker, MRA, and SGLT2 inhibitors. Now, this is the latest which I downloaded from Twitter today. Now, the proposed new sequencing. So far, we have said use an ACE inhibitor, ARNI, beta blocker, MRA, and then angiotensin receptor antagonist. This is the ACC pathway. Now, the proposed new treatment is step 1, start beta blocker and SGLT2 inhibitor because they show the earliest divergence of curve in treatment. So, start SGLT2 inhibitor and beta blocker. Next step is to use ARNI, and finally, we are going to look at treatment with mineralocorticoid receptor antagonist. So you still get the 4 pillars, and you achieve all these 4 pillars within the first 4 weeks. So within 4 weeks, achieve these, and then afterwards, it's going to be up titration of the doses. So finally, the take home is it's a deadly problem. Heart failure with reduced ejection fraction, 50% die in 5 years. When you have a reduced ejection fraction, remember the 4 pillars that I said: the beta blockers, the ACE inhibitors, the ARB, or the ARNI, more importantly, MRA and SGLT2 inhibitors. Clear role for digoxin and nitrates. Don't stop if there is improvement, and heart failure with preserved ejection fraction, probably we have newer drugs that are going to be there. With this, I should say, remember Swami Vivekananda, arise, awake, and stop not until the goal is reached, because the goal is going to be the best. Thank you so much for the patient listening. I don't know how long I exceeded, sir, but I didn't know where to stop. Thank you so much, sir.
Thanks, Prabhakar. I had always wanted to definitely show you that I have got one newer slide, but finally you have disappointed me by showing that slide also, which you have downloaded recently, because the recent one by John McMurray is 4 pillars and not 5 pillars, and the first pillar, as Prabhakar said, is SGLT2 and beta blocker. So The diabetologist now will say for cardiac failure, their drug is the first drug, SGLT2, along with beta blockers, then followed by naturally ARNI and ivabradine and other things. So SGLT2 is now, I think about a few years back, me and Prabhakar has told that will be the molecule like statin for the next decade. I think it is going to beat all the other molecules in the field of cardiology and diabetology. So it's a wonderful drug. So that is why updating is essential. He has updated it, never gave a single room for anyone. He has also given us the Soloist Travel, which is a recent one with sotagliflozin, which is a useful drug for heart failure with preserved ejection fraction. Now we will keep all the questions for the end. Now I invite Dr. Gopala Murugan to tell about the instrumentation in the management of cardiac failure. I do not know what he is going to talk, but I know he has done. He has pulled out many of my patients from Cogmire really to make them survive when they were in cardiac failure with real hypotension. What Prabhakar has put it as the ghost of treatment of heart failure. Gopal Murugan, please.
Thank you, sir. Share my screen, sir. Admin, can you let me share screen?
Satish?
There is a top of 4 icons are there. In that third icon will be a share screen options will be there, sir. You can do that. When you move a cursor in up, there will 4 icons will come, sir.
Gopal is there or Gopal is left? Yes, sir. He is muted. Is muted.
Yeah, I'm back, sir.
Yeah, right.
Gopal Murugan, and that is next to the microphone and video is a share screen. Yeah.
I got it, sir. I don't know whether it will come up.
Yeah, it has come out. It has beautifully come out.
Right, sir.
Management of ADHF.
Okay, great, sir. Thank you, sir. Thanks for having me. I'm very honored. And thank you, Prabhakar, sir. Fantastic talk. Your academic level always, I'm
Amazing.
very amazed by the amount of academic knowledge. And I always learn from your talk. Whatever talk you give, there's always so many things I learn. So I always listen to things that I can pick up and improve my practice. Thank you. Thanks a lot, sir. So I will just go to the easier bit because I can't do academics like you. So I'm just going to go to the non-academic, more acute management styles, largely something relevant that we can do in Chennai because there are so many treatments available across the world. And I always hate to talk about treatments that we cannot adopt anywhere at the present time. So we will just talk about treatments that have been done with follow-up and what has made a difference and whichever is evidence-based also. So I'm just going to stick to the acute management of heart failure that we do here. There is a classification of common clinical characteristics of patients with acute heart failure. You have on the left-hand side this huge list of various kinds of heart failure, but I will not go into this in detail. When you talk about therapies, you can see this picture, and this is quite popular, and they include various therapies such as ultrafiltration, vasodilators, nitrates, diuretics, dopamine, dobutamine, milrinone, inotropes, and ventilation, either non-invasive or invasive. But these are largely treating the effects of acute heart failure. But my interest is largely looking at the etiology of heart failure. அதாவது நோய் நாடின்னு சொல்லுவாங்க. அதனால நோய் நாடி finding out the cause and treating almost always leads to the definitive treatment for acute heart failure, and that's what we're going to concentrate now. This can be either ischemic or non-ischemic. And ischemic, we all know it's coronary artery disease. Non-ischemic, however, can be post-myocarditis, can be arrhythmogenic. This can be ectopic mediated or tachycardia mediated due to AF. Several arrhythmias can cause that. Valvular, critical valvular heart disease can lead to heart failure. Infiltrative, usually long-standing, restrictive, long-standing, and constrictive, again long-standing, but they may present with acute on chronic heart failure. Therefore, looking at the substrate for acute heart failure is very important, and that's something I'm very, very keen on all patients to make a quick decision. Are we dealing with a reversible or irreversible substrate? Because that's the only way you will know how to target your invasive treatments, how to consider various treatments, because everything is expensive and you need to have clear evidence as to whether you're going to make any useful difference for the patient. Therefore, you need to find out, is it a mechanical problem? Is it a valvular problem? Because that's reversible. If it's an electrical problem, it's reversible. If it's a vascular problem, it's reversible. And if it's a muscular problem, some are reversible, some are not. And that's where quick investigations, all gold standard investigations have to be done so that there's no room for screening. Immediately do an echo. I think if there's a scar, it's very obvious. Sometimes you may have to do an MRI, even in acute patients, if they can go in an MRI suite, but makes a lot of difference in finding out the substrate. Let me give you an example. So this is a patient, you will all agree, has a very severe LV dysfunction. His EF, we calculated about 10-11% is what we calculated. Was hardly contracting. You can see the aortic valve is also not opening. Severe aortic stenosis. He was in decompensated heart failure, and his lactate was 14 and pH was 7.1. And he was in pulmonary edema. He was intubated. So therefore, the treatment options are very minimal here, and one would say it's probably too high risk to do anything. But then, whatever you do, you can only make these patients better. They're going to die anyway. So by doing something, if you can make a difference, it's worthwhile attempting, but they have to be done with careful care. So clearly this echo, looking at the substrate, the LV is not thinned out at all. I don't see any scar here. They are fairly thick myocardium. They've just become tired of contracting against a very high afterload, which is critical aortic stenosis. Therefore, there is a possibility that with aggressive management, you can make this patient live. So we immediately wheeled the patient with CT to CT, an intubated patient, and discovered he had critical aortic stenosis but bicuspid. So therefore, these valves will require multiple predilatations, post-dilatations. So if you rapid pace this ventricle, they almost always die on the table. This is my experience. And he's had a previous bypass operation also, but the grafts are patent, clearly saying it is not a coronary problem. The grafts are fine, the vascular system is fine. It's a pure pump issue due to outflow obstruction, and that has to be fixed effectively. So therefore, we put an ECMO on straight away, and after ECMO was implanted, we dilated the valve, and as soon as we dilated, the heart stopped, as you would expect. But because we were on ECMO, we had a parallel circuit, and we put a valve in to open up the aortic valve, did a TAVR, and then post-dilated it. This was all on ECMO support, and we just waited on the table for about 1.5 hours. And after 1.5 hours on TOE, which you can see, we wait for the heart to start contracting slowly. Once the heart starts contracting, we come down on the ECMO flow down to 0.5 liters per minute. And if there is still a good blood pressure, then we can come off ECMO. So for this patient, we came off ECMO on the cath lab table, was intubated, but patient was discharged subsequently after 8 days. Now his 36 months follow-up. This is a patient, if you remember, had a lactate of 14, pH of 7.1, almost a dying patient. But this is his echo now, 3 years down the line. Mitral valves have started to calcify, but then look at the LV. It's beautiful. He's got a normal quality of life. You can see the TAVI valve on the bottom left also functioning normally. So this is just one of those examples which we published back in 2017, but now is more than 3 years. Sometimes, this is a patient of Dr. Sivakadaksham. I thought I should show this. Here, this is a patient, because acute heart failures not always end up in a tertiary center. They can end up anywhere. This is a patient who ended up with acute heart failure in a non-cardiac center. So this is a 65-year-old auditor, LVEF of 15%, severe aortic stenosis, had a VT-VF arrest, had multiple resuscitations in a non-cardiac center, who was inotropic dependent. What do? You cannot shift the patient, you cannot treat the patient there. So we went to that hospital, we went with the full team. Here you can see here on the bottom, the patient was lying there, it was not even intubated. So there, without any anesthetic support, without any cath lab, no imaging. We just used ultrasound. We cannulated the artery and vein, and because the patient had aortic stenosis, you cannot do CPR anyway. Nothing will come out. So we connected him to a parallel circuit, which is an ECMO circuit. Now the patient is an ECMO. He was having VT and VF. Doesn't matter. They will still be alive. We didn't even intubate the patient. With ECMO, we just shifted the patient. You can see here the patient is not intubated. Even if he has a cardiac arrest, we don't mind because we have a full heart and lung support. So we don't need any ventilation also. So we moved him to a cardiac center. He had all his vessels open, did a valve, and was weaned off ECMO on day 3 and discharged at 10 days. Now this is him at 3 years. So you can see here. I hope you can actually make out his face here and on the patient side also. It's the same patient. 3 years down the line, he's a practicing auditor doing very well. So it just goes to show sometimes one might call it very aggressive treatment, but it is the only treatment that saves this patient, but attention to detail. But then they're not all valvular. There are, as I told you, sometimes they are non-ischemic and they are electrical. This is a patient who had tachycardia-induced cardiomyopathy. This is his ECG 12 lead. You can see here narrow QRS, but every QRS is alternating with a broad QRS. Essentially, he's in bigeminy. So the bigeminy burden is huge. Almost 50% of the time he spends in bigeminy, and this is what led to his LV dysfunction and pulmonary edema. We decongested him. We did an MRA. We clearly knew there was no significant scars, so we knew this patient can be cured if we get rid of this arrhythmia. So we did an EP study. Clearly, it is from the ventricles. That's very obvious on the ECG. So we attack the ventricle from the atrium. We do a transeptal. You can see here a tube from the bottom, and also go retrograde from the aorta so that we have both axes approaching the LV. But it's not always easy. Sometimes you cannot burn the arrhythmogenic focus from inside the ventricle because they are outside. So that becomes epicardial. So we tried to burn here, but we could not get the spot at all because we know the spot was outside the LV, i.e. epicardial, not endocardial. If they are not endocardial, you cannot burn with the catheter from the endocardial surface because the LV is very thick and the burns only go up to 3 to 4 millimeters, 1 to 2 millimeters, and they may not reach up to the epicardial surface effectively. And how do we know whether they're epicardial or not? We do an MRI in almost all patients. Almost all non-ischemic patients have scar on the epicardial or the mid-myocardial surface. It's only ischemics where the scar or the arrhythmic focus is endocardial, which means almost always you can get it from the endocardial surface. But anybody who's non-ischemic, it's a very high chance it will be mid-myocardial. If you're lucky, if your burn reaches mid-myocardium, that's fine. If it's epicardial, you have to go to the epicardial space. So for this patient, we had to go to the epicardial space. Again, we do everything in the same procedure. Under local anesthesia, the patient is not intubated. We puncture the LV from the subxiphoid approach, and we reach that 1 millimeter epicardial space, which is between the parietal and the visceral pericardium. And once we reach that space, it takes a lot of time because you don't want to puncture. We pass a fine O14 wire. Once we pass the O14 wire, then we have access into the entire epicardial space. Now we can map the epicardium, find out where the spot is, and then burn. But then once you find out the spot, which is very easy with 3D mapping, you cannot just burn. You have to find out whether the coronaries are there because coronaries are almost always lying on the epicardial surface. So we do a simultaneous angiogram. You can see here the catheter in the epicardial space and a simultaneous coronary angiogram to know how close I am to the coronary artery. After making sure that I have at least a 1 millimeter distance from the coronary artery and I am at the right spot, we deliver the burn. Once we deliver the burn, you can see here on the bottom of the screen, this is the electrophysiological signals. You can see here ectopy, sinus, ectopy, sinus, ectopy, and after half the screen, the ectopy goes away, which means we have burnt off, completely eliminating the ectopic focus in the epicardial surface. It took about 3-4 hours, but that is the nature of these procedures. But unless we deal with it with attention to detail, it doesn't go away. This is his ECG after. Nice 12-lead ECG, not a single ectopy. And now we have followed him for with actually 2 years now. This is his ECG 1 year later, completely lack of ectopy. On the top right hand corner, I've got the previous ECG, which is almost bigeminy now, not a single ectopy, and he has a normal LV and normal NYHA class A. This is just an example of how an electrical focus can lead to acute heart failure, which can be alleviated. What about ischemic? This is probably the commonest cause that we see in our country, and almost always an acute heart failure situation, the best scenario will be to do a percutaneous intervention, unless very rarely they may need emergency surgery. This is just an example of one case who was managed just with drugs, inotropes and PCI. I will not go into the entire angioplasty video, that is not the scope of this presentation, but you can see on the top left and the bottom left hand images how the coronary was before the intervention, and this is after. This patient's heart failure was also alleviated because of aggressive etiological treatment right when he came through the door, just managed with drugs. This is a patient who needed more than drugs. Sometimes they need IABP and pacing, but IABP is only useful if they can generate some blood pressure. Only if they generate a blood pressure, you can augment the blood pressure. Here you can see very critical LAD disease. He required a pacing and a rotablation, and this is just the pre-pictures above and the post-pictures on the bottom, showing the nice angiographic result leading to a pump recovery, and this patient's LV also recovered. And sometimes it's not just IABP, sometimes we need more. This is a horrible coronary. You can see here, it's very displeasing to see such coronaries when they come in. You don't know where to start. Everything very tiny vessels. They can't have surgery either. So we go put an IABP, we go on ECMO standby, open up whatever we can, and stent these vessels to restore some flow, because you can only make these coronaries better. You cannot make it any worse than how they are. And this was done actually 2 years back from transfer from another city, and he's now doing very well, giving another example of how revascularization in acute heart failure can make a difference. Sometimes we use ECMO, but again, I won't show the full angiogram. I'll just show the pre and post images. Just to give an example, various pump support measures can be used as adjuncts to allow safe angioplasty, because you can see here, look at the top angiogram images, completely shut off left main coronary. So as soon as you put a balloon, there will be no flow. During that time, you will need some support, and using a bypass machine in the form of ECMO is useful, and it's all percutaneous and makes a difference. So treatment protocol will be largely to look at the substrate. Is it reversible or it's not reversible? Sometimes if the QRS is greater than 130 milliseconds and LVB, cardiac resynchronization therapy can help. If they have scar or ectopy, they will benefit from CRTD, which is adding defibrillator to resynchronization therapy, and cardiac rehabilitation makes a big difference also. This is an extreme case of CRT and acute heart failure. We decongested the patient. The QRS was about 180 milliseconds, which is probably the longest, the widest QRS I saw. So we thought we'll put a quick CRT, but when you think you do a quick CRT, this patient had a very corkscrew coronary sinus, and this is a coronary sinus where you put anything in, try to push it in, everything falls out. So there was no way we can put a CS lead. So here you can see we managed to discover that this patient had an anomalous vein going up. This is the vein of Marshall. So let me just, in the interest of time, just show you where we could not get the CS. We go to the top. This is the innominate vein. You can see here. From the innominate vein, we try and pass a wire down the vein of Marshall, which connects to the CS. And once it connects to the CS, we come back into the atrium. And once we come back into the atrium, we take another puncture into the vein, bring the snare into the RA, and then we snare it out, which means now you have a complete loop through the coronary sinus of the heart. So here you can see the wire is in the right atrium, and in the right atrium we bring in a snare. You can see here that wire is snared from another puncture from the same side, and it is snared out, as you can see. Once you snared out, you have two wires running through and through the CS. So therefore, the support is completely negated, and you can drive anything from one end to the other. So then after that, we just it's fairly straightforward. You can take a sheath inside. You can see here the sheath is gone in, and then CS lead was placed, and this patient had a successful CRT, narrowing down the QRS from 180 to 120 milliseconds, and he recovered. This is an extreme case of CRT where CRT is used acutely to make a difference to the patient, but this is rare. So the current treatment goals have not changed since 2005. It's largely improving clinical status, increasing functional capacity, increasing quality of life, prevent hospitalization, decrease mortality. What is the clinical protocol we follow? Of course, everybody has clinical examination, ECG, echo. Most of the decisions are based on ECG and echo. I think a good quality echo, I could not stress more how much it can make a difference finding out reversible, non-reversible, and what the substrates are. Cardiac MRI very rarely in acute heart failure, but certainly can be useful in some patients. So the treatment protocol here, we use ARNI in all. We start at 100, as long as the blood pressure is 100, 110, that's fine. Aldosterone antagonist, beta blocker or sinusoid inhibitor, if not tolerated, and diuretic. I won't go into this. I think Dr. Prabhakar sir has made a fantastic talk on this. Some useful interventions in selected patients are block and pace. Sometimes we have elderly patients who have rapidly conducted AF, recurrent admissions. One of the best treatments, and almost always gives a definitive cure, is to block the node and pace, which is we ablate the node, put a pacemaker. They almost never have a hospital admission. In fact, you can stop all negative chronotropes, and this is fantastic for patients. And this is something we do fairly often. And renal denervation, this is a potential treatment now for resistant hypertension. What it means is we ablate using radiofrequency ablation inside the renal arteries. It reduces hypertension in resistant hypertensives where blood pressure is not controlled beyond 4 medications. This is an invasive treatment, but has been proven to be useful in selected subsets of patients. The last one is AFR, which is atrial flow regulator, which is essentially a shunt like an ASD device placed in the intraatrial septum. What it does is it offloads the left atrium into the right atrium. This is a palliation for end-stage heart failure, thereby preventing re-hospitalizations. Our experience, certainly 4 transplant patients have come off transplant list with ARNI and heart failure medications. I'm a big fan of medical management. I think aggressive medical management, as Dr. Prabhakar sir said, with very high dose titration makes a useful difference. And we have seen it in at least 4 patients where, in the last 2-3 years, where transplant patients have come off transplant list. And that is indeed the first line drug for us for acute and chronic heart failure. So to conclude, I think early aggressive treatment is useful because that is the only way these patients who have an otherwise very high mortality can be converted to a near normal mortality. I think etiology and substrate-based treatment makes a big difference, whereby the cause is identified and aggressively managed, which is the only way. Often cost can come in the way, but there isn't a better option to manage these patients. Mechanical circulatory support is something we go very early because they will only work before tissue hypoperfusion progresses. So as soon as the patient is beyond 2 inotropes, the lactate starts going up, they start developing vasoplegia, and once they develop this hypoperfusion syndrome, no matter what you do, they will not make it. So usually getting in early with mechanical circulatory support and avoiding lactemia, tissue hypoperfusion syndromes early makes a better difference for these patients. Early initiation of heart failure specific drugs in hospital, I think I won't talk into this much. Thank you.
Thank you very much, Dr. Gopala Murugan. The first was a melodramatic picture, and the second one was a scientific thriller. And you would all agree it was a real thrilling experience to see the cases coming out almost like Phoenix, a rebirth, a reborn, almost dead and gone with an ejection fraction of 15%, coming back. And finally, he has also said the importance of the anti-failure drugs, as has been explained by Prabhakar. And now the forum is open for discussion. I can see the leading physician, cardiologist, diabetologist of North Madras, Dr. Lakshmanan, and he should be able to tell his experience and any inputs there. You are welcome, Lakshman.
Sure. Done a wonderful moderation. Excellent. I'm enjoying your session very well. Prabhakar, I think I learned a lot from your talk today. I think especially the newer approach to heart failure, your trials on sotagliflozin and things like that. I think well done, Prabhakar. Prabhakar, one question for you. What are the contraindications for ARNI?
Army.
Heart failure.
Army should actually.
I can tell you what's the creatinine cutoff you give for ARNI.
Sir, actually what happens is creatinine seems to improve. The original trial data started using 3 or 4 criteria. They said creatinine of about 1.8, the potassium was 5.2, and the blood pressure at randomization was actually 90 to 95. So if you are going to have a much lower pressure, you can't give, but in the major data, 100 seems to be the starting point for the blood pressure. Otherwise, contraindication wise, if the patient doesn't tolerate it, seems to be one that we commonly talk about. And if your patient is on ACE inhibitor, obviously you can't immediately shift to ARNI because there's going to be an angioedema that's going to happen. That is one thing you have to be a little careful because immediately you can't start. You give at least 36 to 72 hours gap between an ACE inhibitor and this thing. But if you're on ARB, straight away you can convert them. But apart from that, even hyperkalemia, the incidence is much less compared to the ACE inhibitor. All the side effects which are commonly seen with ACE inhibitor seem to be much less. They seem to be faring much better.
But the systolic blood pressure less than 100, you think is absolute contraindication for heart? ARNI?
I have that is where that question of the hypotension with polypharmacy. I put up that slide and say that you don't call it hypotension. Look at it as symptomatic hypotension. So if you are looking at hypotension, I have patients who are actually running around with 85 systolic on 100 milligrams of ARNI. The only trouble is tell them don't take your BP.
Thank you, Prabhakar. Gopal Murugan, I think you spoke very well. I think we are really thrilled with our interventions in cases where we have given up our treatment hope. You have done, you have shown us new modalities of treatment. And what I experienced.
The patient aortic stenosis he showed us, that is, he said my patient. This is none other than our classmate Meenakshi's elder brother.
Oh.
who is still alive and kicking, auditor, practicing.
Since I went and saw him.
Yeah.
After that.
Yes.
Good.
Yes, awesome.
The thriller movie it is.
As you rightly said, SGLT2 comes into this place in management of cardiac failure, where there is severe hypotension and hyperkalemia. And that is where the SGLT2 scores over the ARNI. That's the only place probably. But in the years to come, we will have to see because 30% reduction in heart failure hospitalization and 40% reduction in worsening renal status, which always occurs with cardiac failure. So I think SGLT2 will slowly come in line with ARNI. If not...
Of Shiva is given as 0.5 milligrams of creatinine because more than chance of getting little hypokalemia is high with ARNI. That's what the literature says. But I think we can give it at any creatinine level provided you look for the hyperkalemia. I think the renal function also definitely improves, Prabhakar. I agree with you. Even the renal parameters improve.
There is data to show that there is improvements. And not only that, if you start using these drugs, if you de-escalate, you must make it a point to re-escalate again. If you come down on the dose for some reason or other, and most of the hypotension is because of overuse of diuretics. I think the biggest problem is diuretics. We overdo the diuretics.
Because even the congestion part of it is looked after by the ARNI because it has got the natriuretic peptide which induces natriuresis. That's what the literature says. The escalation of the army is better than escalating the dose of diuretics. I don't know. But I don't think in Chennai, people use less than 200 milligrams a day. They start with 50 milligram BD, may go up to 100 milligram BD, but not anyone goes to 200 milligram BD. Have you used Shiva? 400 milligrams a day?
I've used
I don't
maximum
think
100
so.
milligram BD.
Yeah,
Sir,
that's
I
what.
have a lot of patients on 200 BD, sir, no problem. From 100 to 200 now, nothing happens. That initial phase is the problem. Once you reach 50, 100, 100 to 200, nothing really happens, sir.
I think
And
we
fast rate is
also
very good.
use 200, and as sir said, once they hit 100, there's no problem in going to 200, sir. We have not seen any problem in 200 BD.
In fact, the paradigm heart failure study, they gave loop diuretics for 10 days. Only on the 11th day, they started the patients on RNA. Do you follow that still, or now you straight away start the first day itself?
We start
Subsequent
first
trials
itself.
have changed, no? Subsequent trials have changed. The transition and the other trials have said that pre-discharge you have to start them. Pre-discharge, there's another trial, the Paradigm, Paragon, and one more is there. This clearly said pre-discharge you start them, and before discharge all the 4 drugs should be on board. That is the concept now.
Thank you, Prabhakar. Thank you, Shiva. Thank you, Gopal. I think big salutes for you. Thank you very much. Thank you. Great
Dr. Murugan,
discussion.
how frequently do you see this one tachycardia-induced cardiomyopathy? Because yeah, very rare to see a regular bigeminy, which we see in majority of patients when they come to the clinic going in for cardiomyopathy. How frequently have you come across this?
So I would say about 10%, sir. 10% of the patient. It's a small number, but unless we look for it, we will never get it. Very often, it's atrial fibrillation in the
Which one
elderly.
came first, the cardiomyopathy, dilatation, and VPD, or the VPD and then the cardiomyopathy?
A chicken and egg story, but we'll never know that.
Sir, I
One
can
good
give you a
way,
different answer to that. Anybody with a
almost.
mild LV dysfunction,
What, Prabhakar?
No, we do an MRI in all, sir.
All right.
Usually, if there is a scar, usually it is the LV that's causing the ectopy, because the scar is the nidus for the re-entry ectopy. If there is no scar, usually it points towards tachycardia-induced cardiomyopathy, because if there's no scar, we'll be more aggressive in ablating it. Because if there's scar, the substrate is always there. So whatever you ablate, it may be coming back. But no scar LV dysfunction with arrhythmia equals the arrhythmia may well be the cause for the LV dysfunction. That's how scientifically one can be sure. But
Anybody has any other question? Please feel free to ask.
Sir, chat box 2 questions is there, sir.
Can you please read it out?
Yes, sir. From Dr. Vijay Babu. Dr. Old drug digidoxin also improve the FRF for the HF patients and reduce hospitalization. But nowadays, more choosing RNA, which is more costly, sir. What is your opinion, sir?
Prabhakar?
that's a very simple answer. See, the only benefit of digoxin has been reduction in hospitalization for heart failure. It doesn't provide survival benefits. Ultimately, mortality reduction. Your patient has to live. He will not have heart failure, but he will die ultimately. The survival benefits are proven with the drugs that we have mentioned. So that is the problem with the digoxin.
Yes.
That is the reason why digoxin has not. But digoxin has found a recently new heart. Because digoxin, we said don't use digoxin even in heart failure with atrial fibrillation. Use beta blocker, mortality can be high. But no, now there is a recent data which said it is as good, in fact, slightly better than beta blockers in atrial fibrillation with heart failure. So you can start using digoxin in atrial fibrillation heart failure. So don't worry, it is there specifically indicated. But if you are having a refractory heart failure, you still add digoxin, not a problem. But the other drugs are more beneficial. It is expensive, agreed. But now most of these drugs, generics are started. You start getting most of the generics. So I think cost will come down over a period of time. So one point about what Gopal was telling about the ventricular ectopics. See, when you have a patient with mild AV destruction and ventricular ectopics on your ECG, or they find some irregular beats or palpitations, you do a Holter, which is a very useful tool there. You can find out the load, and if there is a deteriorating LV function. I had a patient with mild LV dysfunction whose ectopic load was not very high, but
What is the percentage?
it was actually about 5%.
Pardon? 10% or?
Sir, it was actually about 5%. No, it was actually 5% initially. When she had a mild LV dyspnea, I thought it's not going to be a problem. I started a beta blocker. Then she came with frank cardiac failure, and then I realized that the ectopics are much more. And at that point, she had about 30% alternate beat. She was in ventricular bigeminy, and she also had episodes of SVT.
So
That
the
patient was actually
indication,
antenatal.
the ectopic burden indication, sir, for ablation is about 20%.
20%. Yeah, that's what I want.
So 20%.
But do you have to do it even if the LV function is normal?
No, if the LV function is normal and the patient is asymptomatic, you don't have to do anything at all. You can just keep them on surveillance. Just surveillance, you can keep them on surveillance. If their LV is not deteriorating on echo and the patient is asymptomatic, we don't need to do anything on ectopic. A lot of patients get referred for ectopics because usually it's incidental finding, but these are benign ectopics. And how do we know it's benign ectopics? Family history. There's no family history of sudden death, no high risk symptoms such as shortness of breath or syncope. And if the LV is normal, usually we do an MRI, no scar, structurally and functionally normal heart with no symptoms equals benign ectopy, and they don't need any therapy whatsoever. And if any of the others, then they become malignant hypertrophy, and you'll have to deal with it accordingly.
I think the admin has asked one question. Combining ARNI, SGLT2 inhibitors, diuretic precautions to avoid worsening renal function. The SGLT2 will take care of the worsening renal function because it has been proved beyond doubt in Emperor Reduced and DAPA-HF that 40 to 50% reduction in progression of renal failure worsening has been found with the SGLT2 more than MACE. MACE is reduced only from 2 to 15%. Cardiac failure hospitalization by 30%, whereas worsening renal status is reduced by 40 to 50%. So I don't think you should have a worry about this particular point. I think we have had a wonderful discussion, and there are a lot of take-home points from both the discussions. As rightly said, we have learned when to intervene, and from Gopala Murugan, and how best you can treat cardiac failure from Prabhakar up to the latest VSU have got. And I think we should try to put it into our practice because both of the talks are based on randomized controlled trials and real world experience of patient survival. I think it's a real good feast that we had this evening. Thanks to Cipla and thanks to both of you. Thank you.
Thank you, sir.
Thank you.
Thank you, doctors. Thank you for so much of informative and interactive section, sir. Thank you very much once again from Cipla, sir.